And now we move on to the last, which this time, instead of keeping a lecture, we've kept an open house session, because in the previous two master classes, there were several questions or several aspects which we could not cover. So for this, I have a panel. All the faculty members who are present, obviously, will continue to be there. And I have Ajay Sharma, who's my colleague. He's the Chief of Surgical Gastroenterology at the Mahatma Gandhi Medical College Hospital. All the faculty, please come in, put your camera on. Dr. Deepak Mittal, who's my and Sadiq's colleague from All India Institute of Medical Sciences way back in 80s, and who's currently a transplant surgeon in Chicago in US, and he has special interest in islet, so I requested him to join. We have Dr. Jayanti Venkataraman from Chennai, and I also have my colleague from palliative medicine department in my hospital, Dr. Nipun Lamba, and of course Yogesh has been participating. So what we will do, that since Deepak is abroad, he may have it's daytime for him, he may have commitments, so I'll request him to cover his topic first. So he'll tell us a little bit about total pancreatectomy and islet autotransplantation in about 5 minutes or so. Deepak, please.
Thank you, Dr. Kapoor, and the organizers and moderators and the people who are attending late at night. So with full disclosure, I'll tell you, I am a pancreas transplant surgeon. I don't do pancreatic surgery at this time. I did that way back in the past with Dr. Nandi and Dr. Kapoor. So I was asked to talk about islet autotransplantation and total pancreatectomy by Dr. Kapoor. So this is indicated in a very small subset of patients with benign disease who have either small duct chronic pancreatitis or idiopathic or genetically related acute pancreatitis or hereditary chronic pancreatitis with a cancer risk. Also, if there's failure of conventional surgery for chronic pancreatitis, or if somebody has extensive trauma or benign pancreatic pathology. So you have to be very selective, because once you do a total pancreatectomy, these people have very severe exocrine and endocrine failure, which is very hard to control. Even with islet autotransplantation. But for patients who are candidates for this procedure, it is a very good option. Now, when should you not do this? You should not do it in patients who have pre-existing type 1 diabetes, requiring a lot of insulin, or steatohepatitis, if they already have portal vein thrombosis or portal hypertension, because you inject the islets in the portal vein if they already have portal vein thrombosis or portal hypertension, then it's not a good idea. If they had a previous lateral pancreatic jejunostomy, obviously you'll not take the pancreas out. Or if they have psychological issues where the pain is, narcotic dependent, and they, even despite the pancreatectomy for pain, they're not going to do well. So once you do a pancreatectomy, a total pancreatectomy for chronic pain or the other indications I talked about, it has to be done in 2 stages. First, you do a distal pancreatectomy, resect the body and tail of the pancreas. And second, you do a pancreatic duodenectomy with the head and uncinate process. And usually it's done open, but you can do a robotic assisted, robotic approach now with, advances in robotic surgery. So to minimize ischemia to the islet tissue, you preserve the gastroduodenal artery and the splenic artery till just prior to the resection. So you can preserve the spleen with the short gastric vessels, and occasionally with the splenic artery and vein, but very rarely. So as soon as the pancreas is removed after devascularization, it is placed in cold preservative solution. You cannulate the pancreatic duct and inject collagenase and preservative solution. The idea is to separate the exocrine portion of the pancreas from the islets. The islets, unfortunately, undergo some ischemic issues here, lack of nutrition, and end up with starting some apoptosis. That being said, after the collagenase separation, you end up with a small pellet which can be infused into the portal vein. Now, this can be done at the same time as the original surgery for chronic pancreatitis. You can inject the islets in the portal vein. If you see a rise in portal pressure, then you can stop the infusion and inject the islets into the submucosa of the bowel or the omentum. Now, this has been proved to work in animals, but uncertain if it works in the clinical human model. After you do this, 1/3 of patients will get insulin independence or a positive C-peptide where the diabetes is less brittle. So it's definitely useful. In children, you have a higher rate of success. If they need total pancreatectomy, the success rate can be up to 50%. The longest period of insulin independence seen so far with this procedure is 12 years to 15 years. Again, I'll emphasize this for a very selected group of patients. So I'll stop there and answer questions.
So, why is it that this procedure hasn't become popular? Is it because of the poor results, or is it because of the poor or because of the complications?
So, essentially, first of all, you need to have a lab to process the islets, and not every center has approved lab where you can do this processing. Now, most of the centers like Minnesota or Cincinnati or University of Chicago, they already do islet transplantation for diabetes, for patients who have type 1 diabetes who are not candidates for a solid organ pancreas transplantation. They may do well with islet cell transplantation from 1, 2, or 3 donors, and they get insulin independence. So you have to have a center, a large center where you are able to process the islets. Then the islets undergo trauma. When you do the total pancreatectomy, this pancreas is already diseased and fibrotic, and in separating the islets from the exocrine tissue, they undergo more trauma, ischemia, and then when you inject them in the portal vein, they're obviously devascularized for 2 to 3 weeks, at which point revascularization happens. Until that period, you have to maintain a very tight glucose level with giving intravenous insulin on an insulin pump initially, because otherwise there's hyperglycemia. The islets get damaged even more. So it's, first of all, the availability of a lab to process the islets, and then the success rate depends on engraftment of the islets.
2 quick comments from Yogesh and Sadik, and then we move on to the next. Yeah, Yogesh.
Yeah, Deepak, I have been listening to many talks at the Pancreas Club meeting regarding this islet transplantation in chronic pancreatitis. And to be honest, outside of those centers, nobody understands what type of patients are treated, because the patients treated there have no morphological correlation what otherwise we address as chronic pancreatitis. So, I mean, is it some different disease, or is it a treatment option for a very early stage? Also, the long-term results with the islet transplantations are not truly convincing, because many of them become diabetic over the period of time.
Absolutely. I agree with you. That's why this procedure of total pancreatectomy for benign disease for chronic pancreatitis has to be very carefully selected. You have to tell the patient their expectations should be such that they will require a lot of pancreatic enzyme with every meal. The diabetes may not be cured permanently. So I quite agree with you that this has really not taken off. Like if you do islet cell transplantation for diabetes, in patients who have kidney failure. They get a kidney transplant, they get islet transplant. The results are much better now. So I agree with you that in chronic pancreatitis, you cannot do it for every patient with benign disease, and the results are not the best. But in a third of patients, it's great. You have insulin independence or less brittle diabetes, which can be managed, because if you do a total pancreatectomy, there is brittle diabetes. Hemoglobin A1C is way above 9. And they get exocrine insufficiency.
Sadiq, quick.
Hi, Deepak. I just want to know that, is there a way to determine, because the results will depend on the islet yield, the quality of the islet, and the ability to sort of dissolve or digest the pancreas and get the islets. So, is there a way to assess this before the surgery to know that this patient or this pancreas will have a good yield and good islets?
Well, that's a great question, but that's like predicting the weather 3 months from now. It's all, could be cloudy with a chance of meatballs. No, there isn't. The short answer to your question is no, there isn't. But if somebody is needing a chronic, total pancreatectomy for chronic pancreatitis, then you do it. You tell the patient to have expectation of about a 1/3 success rate for the, cure of diabetes. But if it happens, usually it's durable. If the islets engraft, and you're right, it depends on the total islet yield and the purity of the islets and the number of islets. So, a good point.
I know Roop Jyoti and Ramesh want to say something, but I think we need to move because there are two other people. So if Deepak is staying, we'll come back to you.
Sure.
Yeah.
Sure.
So I think next I would request Dr. Jayanti to make a presentation on autoimmune pancreatitis, because that was not covered in the main program. And I thought that is an important topic.
Can I share my slides, sir?
Please.
It's coming as disabled participant. Share. Please allow me to share the slide.
No, we don't see it as yet.
I put her in spotlight. Does that help? Just try again.
Can you see my slides?
No.
It's not
While
been
the
shared.
slides are coming up, Roop Jyoti, you want to say something quickly?
So in this discussion, actually, islet transplant in chronic pancreatitis is mainly done because of pain. So that total pancreatectomy, the pain goes off. That's the basic concept. And University of Minnesota has a very low threshold actually for this, and they would do even for a normal duct disease or small duct disease. But the problem here is we are forgetting the pain. Of course, islet technology has developed. We do islet transplant for patients who require distal pancreatectomy, not for primary pain relief, but for giving back their islets. So it has been seen even after total pancreatectomy, 40% still continue to have pain. So that's a concern. On one hand, 1/3 patients only are insulin free. And on the other hand, 40% continue to have pain. So I think in chronic pancreatitis, we should still be very careful to use islet transplant as an indication. And many of these patients already undergo some kind of ductal intervention that reduces the islet yield and increases the risk of contamination. So I think that's what I would be very reserved to use islet transplants and a total pancreatectomy. So that's what I wanted to say. Yeah.
Dr. Jayanti, please.
Slides, sir?
Yes, we can see. Please.
Thank you, sir. And thank you, sir, for this kind invite. In the next few minutes, I'll give a brief glimpse of acute or autoimmune pancreatitis from surgeon's viewpoint. So why is this topic important? It is because many of the times following a surgical resection, we've seen that patients with suspected pancreatic carcinoma, in fact, have a benign pathology, and about 1/3 of them actually constitute an autoimmune pancreatitis. And recurrent pancreatitis has also been described in patients with autoimmune pancreatitis, and some of them even present as chronic pancreatitis with exocrine and endocrine insufficiency. And I think the most important issue is whether this particular autoimmune pancreatitis is actually a pre-malignant entity and therefore they require long-term surveillance, or in patients who have a focal enlarged pancreas, how does one actually get through whether these patients do in fact have a pancreatic adenocarcinoma? So by definition, autoimmune pancreatitis is a benign, rare, distinct fibroinflammatory form of pancreatitis. And typically it's characterized by pancreatic pain in about 40%. Obstructive jaundice is the most common presentation in about 70 to 80%, with classical histological features of lymphoplasmatic infiltrate and fibrosis. And they have a dramatic response to steroids. So we have the type 1 and type 2, and what we see in our part of the world is we have the type 1 autoimmune pancreatitis, commonly seen in Asian countries, often in men in the 6th decade, and most of them have other organ involvement, and that is quite common in these patients. IgG4 is a common finding in our patients, and relapse is common even after treatment, unlike type 2, which is uncommon and not seen in our day-to-day practice. So in large surgical case series, although we talk so much about autoimmune pancreatitis, the overall prevalence is quite rare. It is about 0.7 to 2.4% amongst the various surgical cases that have been operated, thinking that they were patients with pancreatic malignancy, and many of them had other organ involvement, of which biliary was the most common other organ involvement. And in post-op resections, it was also seen that type 1 was the most common type of patients who had a resection. And in these patients, the IgG4 was quite common in type 1, and relapse rates were very high in these patients. And this was seen, and this is supposed to be what was seen in most of our patients from the Indian subcontinent as well. So these are some of the series up till 2022. Type 1 seems to be still the most common type. Other organ involvement is not so common, and relapse rates are very high even after surgery. So we often have a problem of differentiating autoimmune pancreatitis from pancreatic carcinoma. And despite the fact that we have high-end imaging techniques like CT, MRI, MRCP, the sensitivity is quite low with most of these imaging modalities, but specificity is fairly high. And despite this, attempts have been made by several workers to distinguish the so-called mass-forming lesions in autoimmune pancreatitis from pancreatic adenocarcinoma. Amongst them, the duct penetrating sign and the collateral duct dilatation seems to be the most common, and distinctly absent is the double duct sign, the displacement of the calcification, the duct to parenchyma ratio, and the superior mesenteric artery to superior mesenteric vein ratio, that's more than 1. Most of the findings are more in favor of a pancreatic adenocarcinoma. So despite this, it is quite difficult in a given situation to distinguish between these two. Other findings are the vessel encasement or deformity, as Dr. Ramesh was saying, in chronic pancreatitis. Sometimes it's an inflammatory process that causes this changes in the arterial wall, and at times it may be mistaken for a pancreatic malignancy. With FDG PET, in most of these patients with autoimmune pancreatitis can have a diffuse or multifocal accumulation in pancreas, and that would help us to say that probably we are dealing with an autoimmune pancreatitis. So to summarize, a workup of autoimmune pancreatitis should involve a basic liver function test or liver biochemistry, and this is more important in patients who present with obstructive picture. Serum immunoglobulin, the IgG levels and IgG4 levels are absolutely important. This will help us to distinguish some of these patients. High-end imaging, which includes the CT and MRI scan, is absolutely necessary to distinguish the mass lesions in autoimmune pancreatitis from pancreatic adenocarcinoma. Of course, in some of the situations, one may have to resort to a histological diagnosis using the endoultrasound. So when we do get a patient and we find a mass lesion in the head of the pancreas, and we are in a dilemma as to whether we are dealing with pancreatic duct adenocarcinoma or we're dealing with an autoimmune pancreatitis with a mass, if we have a typical finding such as diffuse enlargement of the pancreas with a delayed parenchymal enhancement with or without capsule sign, along with any non-ductal imaging markers such as serum IgG4 or other organ involvement, I think we're justified in treating these patients with steroids. If, on the other hand, these patients have focal segmental enlargement of the pancreas, or there are other features such as low density mass, suggesting mass related to the head mass, then we have what is called as a collateral evidence. This is being discussed by Dr. Chari and others. And if the evidence is strong, and the collateral evidence is very strong, and if we have two of the three that is shown here, the PD stricture, the serum IgG4 more than 2, or histological confirmation of other organ involvement and radiological evidence of this thing, then these patients also be justified in treating with steroids. On the other hand, if it is modest and we have only one of the other three findings, then we are justified in taking doing an FNA with an endo ultrasound. If it is negative, then we can give a trial of steroids, wait for 2 weeks, reassess the patient, and then take a call whether we are dealing with a pancreatic head mass due to adenocarcinoma or an autoimmune pancreatitis. So the key message in autoimmune pancreatitis is it is very important to differentiate when there's a mass lesion to distinguish AIP from a pancreatic carcinoma. Always estimate a serum IgG4 level. One must have a good imaging, especially with the pancreatic protocol, with the CT, MRI, MRCP, and at times even ERCP. And there's a definite role for endoultrasound, especially in indeterminate cases. And I think we're justified in treating some of these patients with steroids. Wait for 2 weeks and see whether when there is a mass and there's a huge doubt whether we're dealing with adenocarcinoma or not, and then reassess the patient to take a call whether we're dealing with autoimmune pancreatitis or a mass related to adenocarcinoma. I think in the present days, there are very minimal chances that we are likely to miss an autoimmune pancreatitis with a mass lesion due to a carcinoma head of pancreas, especially with the high-end preoperative diagnosis using the computed tomography, the MRI imaging, the endoultrasound, and histology. And of course, this will definitely prevent us from doing unnecessary surgery in many of our patients. But despite that, recently we did have a patient at Global Hospitals where the patient did have jaundice, obstructive jaundice. He was a 70-year-old male, and lo and behold, at the end of it, after surgery, the post-op report did come as IgG4 related pancreatic head mass. Thank you, sir, for the kind invite and attention.
Thank you, Dr. Jayanti. Since we have to finish at 9, we want to keep to time, and I have Nipun with me. This topic I kept because it's a frequent question in the theory exam for the students. So I suppose if you write even half of what Dr. Jayanti has told, you will pass. So now I invite Dr. Nipun Lamba. We have a palliative care medicine department in our hospital, and I request him, although many of these aspects have already been covered in various talks, but he would like to summarize to us what is the pain management for chronic pancreatitis. Nipun, please.
Thank you very much, sir, for inviting me. I am Dr. Nipun Lamba, Associate Professor in Department of Pain and Palliative Medicine. I have done my fellowship in pain management as well as palliative care. So today we are talking about pain in chronic pancreatitis. First of all, I will be very short and precise. We follow WHO step ladder whenever we are dealing with any chronic pain. And pain in chronic pancreatitis is sometimes very severe. We start with usually NSAIDs, and then we move up the ladder along with adjuvants like gabapentin, pregabalin, and other NSAIDs. If the pain is relieved not from the step 1, then we move to step 2 of the WHO analgesic ladder, in which we are taking mild opioids like tramadol, etc., tapentadol even. And if it is not relieved even by then, we can switch to the step ladder 3. Step ladder 3 is having stronger opioids like morphine, fentanyl patches. These things are available to us, and they are freely available in our hospital also, Mahatma Gandhi. If pain is not even managed by them, then we resort to interventional pain management techniques. So after WHO step ladder 1, 2, and 3, we are going to interventional pain management. If pain is very severe, that we analyze that pain is not going to be relieved by WHO ladder, then we can shift to the interventional pain management even at the stage 1. But usually we follow the ladder and then we go to the IPM. So in interventional pain management, we are having many techniques for control of pain. We are having celiac plexus blocks, which is very useful. And apart from it, we are also having splanchnic nerve blocks. Block is a generalized term. Usually when we are using block, we mean we are using local anesthetic and depometrol. But what we are doing is we are neuralizing the ganglion. We are doing celiac plexus neurolysis, which is a very effective in managing chronic pain. And if pain is not even relieved by celiac plexus block, and then we can resort to splanchnic nerve blocks. As we can see, know that there are greater, lesser, and least splanchnic nerves, T5 to T10, T10, T11, T11, and to T12. So we can block these splanchnic nerves. And also nowadays, there is an added advantage of radiofrequency ablation. These machines are available, these techniques are available. And what we can do is we can ablate these splanchnic nerves individually. And that can help us to relieve the pain. So the pain which is not even relieved by neurolysis, we can relieve by radiofrequency ablation of the splanchnic nerves. And apart from that, there are also when sometimes the pain becomes very severe and we have done the blocks and we are not able to control it. So in addition to it, we are having intravenous lignocaine infusions. Lignocaine is a local anesthetic, sodium channel blocker. So we are giving it in a dose of 2 to 5 milligram per kilogram. We are giving 3 to 4 settings. And it usually relieves the pain of, it helps in relieving the pain of chronic pancreatitis, intravenous lignocaine infusion and intravenous ketamine infusions also. Ketamine is an NMDA receptor blocker, and we are using it in combination with propofol and slight midazolam in very less amount, like 1 or 2 milligram. So intravenous ketamine and infusions are also very helpful in relieving the pain associated. So this is how we are managing our pain of pancreatitis as well as cancer pain. And we have performed in our institute various celiac plexus blocks as well as splanchnic nerve blocks. Yes, the results are sometimes dicey, but that's a part of practice, and we try to improve as we go on. But the success rate in these procedures is usually good. Patient gets good relief, and if we are able to manage the pain by medications after giving block, then we call it a success. We consider it a successful procedure. And thank you, sir.
Yeah. There is a question that what is the duration of action of these blocks?
Yes, sir. If we are doing neurolysis, we are expecting 4 to 6 months pain relief at least. And in CA pancreas patient, usually that's a good duration of pain relief. The duration of relief outlasts the longevity of the patient. And if we are doing radiofrequency ablation of splanchnic nerves, which we are now doing these days, so that lasts for about 2 years. And that is very useful technique as well as far as chronic pancreatitis is concerned, because in acute and chronic pancreatitis, there are reversible situations sometimes. But the CA pancreas is not reversible. So we don't neuralize in case of pancreatitis. We are doing radiofrequency ablation of splanchnic nerves, and it lasts for about 2 years. Local anesthetic and steroids are just for diagnostic purposes we are doing. We are not using as a treatment modality. We are either neuralizing or doing radiofrequency ablation.
Thank you. There is a comment which I have to read for the sake of the delegates given by Dr. Puneet Dhar, that Dr. Sudeep Shah has suggested that we should look at globulin levels when we are thinking of AIP, because it is less expensive than IgG4. And if total globulin is less than 2, then it is unlikely, very unlikely that IgG4 will be high. So it could be a good screening investigation before asking for IgG4. So with that, exactly at 9:01, I would like to close this masterclass, and I would like to thank all the faculty and all the delegates who have joined. Today we had about 60 plus people watching it on the YouTube, and yesterday's session, Himanshi, Dr. Avinash's team informs me, has already had more than 800 or 900 views. So this is the information about Jaipur Surgical Tutorial. Students who want to join JST, please send a WhatsApp message to Dr. Anand Nagar. And students who want to read a little more about chronic pancreatitis, send me a mail and write CP in the subject of the mail. And I would also like to acknowledge the technical support provided by one of my former fellows, Dr. Avinash Tank, who's currently working at Dwarika Hospital in Ahmedabad. So with that, we will... Dr. Ramesh wanted to say something about ILET. So since Deepak is still there, Dr. Ramesh, please, 1 minute.
No, I think in the late 1990s and early 2000s, we had a pilot study on extracting islets from patients with Indian pancreasis. We found that the extreme fibrosis that is associated with the pancreatitis in India, they just didn't centrifuge out, and we had trouble separating the islets. I wondered whether there was new technology that made all that absolutely, like falling off a horse. I wanted Deepak to comment on that.
Sure. you're absolutely right. If there is severe chronic pancreatitis with a lot of fibrosis, it can be difficult to separate the islets from the exocrine part of the pancreas. So, you can definitely try it. And if successful, whatever amount of islets you can get out of the pancreas helps. You inject it into the portal vein. And I think the patients have to be counseled before doing this, not to expect anything more than maybe 15-20% in these cases of insulin independence.
Thank you.
Yeah. So Avinash is there. Once again, thanks to Avinash and his team for the technical support, not only to the master classes, but to all the activities of the Jaipur surgical tutorial. So with that, good night, goodbye, because we want to
Good
keep
night.
you the time, start at 7 and finish at 9. Thank you very much. Thank you all.
Thank you very much.
Great session. Good night, Vinay. Bye.
Bye.